I'm seeing a few people come in, which is lovely, and welcoming everybody to our Access Presents event. I am Lindsay Jibb. I am a scientist at the Hospital for Sick Children and an associate professor in the Faculty of Nursing at the University of Toronto and a former sick kids pediatric oncology nurse. I have the privilege and pleasure of being a co-lead on the ACCESS Matrix 7 Psychosocial and Survivorship group alongside Fiona and Megan. So really my pleasure to be here today. To start us off, I'd like to take some time to read through a land acknowledgement. So ACCESS respectfully recognizes and acknowledges the relationship the First Nations, Inuit, and Métis across Canada have had with the land that all Canadians live on and cherish. As we work to create, implement, and continue this pan-Canadian network, we would like to consider each of the 634 different First Nations communities, 53 Inuit communities, and 8 Métis settlements who have a unique historical, cultural, spiritual, and environmentally sustainable connection to the land that their people and ancestors have inhabited since time immemorial. ACCESS is committed to working to build relationships that include First Nations, Inuit, and Métis peoples. ACCESS is a pan-Canadian pediatric cancer network advancing childhood cancer experience, science, and survivorship. Our network of researchers, healthcare providers, partners, and persons with lived experience is united by a shared commitment to equitable access to research, innovation, and care for children with cancer and their families in Canada. One of the ways that we do support these objectives is by hosting free educational sessions such as this, ACCESS Presents, throughout the year. These sessions are really designed to share updates and highlights from a variety of experts in the pediatric cancer space. And so today we're very excited to have you all here to join such a session. So to give a little bit of a preface to what we're going to speak about today, ACCESS presents psychosocial screening recommendations in pediatric cancer. Current practice guidelines in pediatric cancer do recommend routine psychosocial screening for families. However, widespread adoption of systematic screening remains limited, in part due to the large number and variability of available screening tools. Recently, our research matrix completed a scoping review of psychosocial screening tools and resources available for the pediatric cancer community. The findings of this review, we hope, will ultimately help consolidate available resources into a single evidence-based tool to streamline and support psychosocial screening practices. And so I want to thank you ahead of time for joining this educational session to learn more about the priorities of the psychosocial and survivorship research theme and its latest efforts towards standardizing psychosocial screening in Canada. So I now have the great pleasure of introducing our speakers for today. Dr. Fiona Schulte is co-lead of the psychosocial and survivorship research theme at ACCESS, a psychologist at the Alberta Children's Hospital and associate professor at the University of Calgary. And Megan Easton is co-lead also of the psychosocial and survivorship research team at ACCESS, parent of a childhood cancer survivor and a patient family representative on the Canadian Association of Psychosocial Oncology Board of Directors. And I've had the great pleasure of being able to work with both of these wonderful ladies for a number of years. Really ask now that you do feel free to send your questions via the question and answer chat button at the bottom of your screen throughout the talks. And Fiona and Megan, I'm sure will be happy to address those questions once they have made it through their talk. So we'll now pass the mic over to our speakers. Thank you.
Thank you so much, Lindsay, for that wonderful introduction. And thank you so much to ACCESS for giving us not only the opportunity to present here this afternoon, but really the opportunity to conduct this work. This afternoon, the title of our presentation is Psychosocial Screening in Pediatric Cancer Recommendations from the ACCESS National Consortium, where we're going to share some of the research that Lindsay alluded to and then talk about next steps within our research matrix. I am going to give just for those of you, I'm sure most of you are familiar because you're here today, but just a little bit of a background into ACCESS, and specifically wanted to focus in on the work of the Persons with Lived Experience Network and the Psychosocial and Survivorship Research theme, which is where our group has been focusing our work. Then want to introduce the idea of screening for distress to the group, and then talk about the work that we've been doing to try and advance screening for distress in pediatric cancer across Canada. So ACCESS stands for Advancing Childhood Cancer Experiences, Science, and Survivorship. And the goal of ACCESS has been to create a national network of clinicians, researchers, healthcare workers, and other stakeholders involved in pediatric cancer to harmonize efforts and increase the efficiency and impact of pediatric cancer research. ACCESS received 2 years of funding, approximately $22 million, to support the creation of this network. And we've recently been awarded a no-cost extension to extend our funding until 2027. As Lindsay mentioned, ACCESS is made up of a variety of thematic matrices and working groups, including cancer biology, clinical trials, access to innovative therapies and optimal care, regulation, policy and economics, education and training, our research theme, which is psychosocial and survivorship, and then knowledge mobilization and social justice, indigenization, and the inclusion committee, which stretch across all of these research themes. So you can see the work that's conducted within ACCESS really spans the whole spectrum of research that is occurring within pediatric oncology across Canada. The mission of ACCESS is to ensure that every child with cancer in Canada has access to the latest scientific advances, diagnostic tools, innovative therapies, and supportive care leading to better health outcomes and quality of life. And the key goals have been to produce research that will influence policy and practice based on better science, better access, and better coordination to improve the quality of life of children living with cancer, to provide a centralized hub for educational support for patients, survivors, families, and advocates, and to develop a training and mentorship program. And I think, I hope that the work that we are sharing with you today is I believe, a really good demonstration of ACCESS and what we've been able to accomplish through ACCESS and the power of having this national network to move some of our research forward. A critical piece of ACCESS, and I think what has made ACCESS so unique, has been the focus on people with lived experience and creating a network of people with lived experience within ACCESS. ACCESS recognizes the importance of including diverse perspectives and insights of people who've been directly affected by pediatric cancer to drive meaningful improvements through research, policies, practices, processes, and programs at all levels of ACCESS. And the goal of the People with Lived Experience network is to create a safe social space for all people with lived experience, to foster collaboration and leverage the unique insights and experience of these individuals, to provide advocacy development and learning opportunities, and to maintain ongoing communication between people with lived experience and ACCESS. And so now I'm going to turn it over to Megan to share some of her experiences being a part of the People with Lived Experience Network.
Thanks, Fiona. So just for context, I met Fiona when she was president of CAPO, the Canadian Association of Psychosocial Oncology, and I applied to join the board of directors in 2021 as a family representative. So at the time, I had just discovered that there was a whole field called psychosocial oncology, dedicated to the very issues that I felt were largely unaddressed in my family's experience of childhood cancer. and I was thrilled to learn about her work. Last year, Fiona asked if I'd be interested in joining the ACCESS Psychosocial and Survivorship Matrix as a co-lead. And I had been following the evolution of ACCESS since its founding. And as Fiona said, I knew it to be committed to integrating the voices of people with lived experience. So I jumped at the opportunity. It's only been a short time, but since then, I've felt meaningfully included both in the psychosocial and survivorship group and in ACCESS as a wider organization. There's frequent and regular communication around opportunities for people with lived experience to get involved in research and clinical projects, and also efforts to just facilitate social connection and networking opportunities among us. So in my experience so far, ACCESS definitely walks the walk on patient and family partnership.
Thank you so much, Megan. So this is our the co-leadership of this psychosocial and survivorship matrix. Dr. Lindsay Jibb, who you met at the beginning, Megan, who is presenting with me. We have Dr. Leandra Desjardins, who you will hear from at the end of this presentation. Victoria Forster, who's another one of our patients with lived experience. Chantel Thurston, who is another one of our people with lived experience. Dr. Paul Nathan, Dr. Sapna Oberoi, and myself. And so we have been working together over the last several years to try and advance some of the priorities within the psychosocial and survivorship matrix through ACCESS. The aim of the psychosocial and survivorship matrix is to advance the well-being and quality of life of patients, survivors, and their families through the identification, prevention, and management of long-term physical, emotional, and/or cognitive effects of disease and treatment. And so when we first came together as a matrix, we started discussions about what were the opportunities within our matrix, within ACCESS, the opportunities to come together as a national group and think about what the national priority should be. And very quickly, we thought about the opportunity of screening for distress as being a key initiative for our research group. For those of you who may or may not know, within the adult cancer space, there was a movement a number of years ago now to recognize distress as the 6th vital sign after temperature, blood pressure, pulse, respiratory rate, and pain. And the idea behind recognizing distress as the 6th vital sign was to advocate for the fact that distress should be measured in the same way we measure temperature, blood pressure, pulse. And so within the adult oncology space, there has been huge efforts to standardize this within as standard of care, and there is it is now recognized as a standard for adult oncology. Pediatric oncology, we've lagged behind. I'm now going to ask Megan again to share her experience as a caregiver of what her experience was like without screening.
Okay, thanks, Fiona. So I'm the parent of 2 daughters. They're now aged 15 and 18. My younger daughter, Emmy, was diagnosed with ALL just shy of her 3rd birthday. And she was in treatment at SickKids until she was about 5.5. From day one, she received exceptional care from a team that showed her unwavering kindness and dedication. After the shock of diagnosis and the intensity of the first months of treatment, however, I began to feel the absence of something in her care. And I just want to pause here to emphasize that this story is in no way a critique of the care we received at SickKids. Over a decade ago, children's hospitals didn't have the resources and administrative backing or expertise to provide a great deal of psychosocial support, and distress screening, as Fiona mentioned, was patchy at best across Canada. So I didn't have the language at the time to name it, but I had the sense that no one was formally addressing the non-medical implications of Emmy's world being turned upside down. I was acutely aware of the shattering impact of cancer on her body, her mind, and her heart. Yet her mental and emotional distress was rarely, if ever, part of the conversation with the care team. And so I had questions running on repeat through my mind during every interaction with the team, but it never felt like the right time to ask. For example, what's a normal 3, 4, or 5-year-old emotional response to all of this? What level of sadness or fear or anger should I expect to see in her? Does she need help processing these emotions? And if so, how do I do that? Most of all, I just wondered how much her emotional and cognitive responses mattered in her overall healing. I have vivid memories of the 2 or 3 times that a care team member asked about Emmy's mood or emotions, because I felt so excited about there being an opening to maybe ask a few questions. But overall, the subject of her distress, it felt like an add-on, not a must-have in her care. As a result, I didn't seek the support that maybe could have benefited her at the time and prevented future suffering. Emmy's distress mostly showed up as anxiety behaviors, which ebbed and flowed depending on the intensity of the stage of treatment she was in. So in addition to managing her critical medical care, I felt the additional burden of monitoring and assessing her psychosocial well-being with no real guidance. To sum up, without distress screening, there was no validation of my belief that Emmy's experience beyond the medical and physical were worthy of attention and assessment and care. And most important, there was no clinical feedback on how to alleviate her distress.
Thank you so much, Megan. I really appreciate you sharing your story and your experience. And I think Megan is not alone in her experience and her perception of feeling that there is a need to measure and validate feelings of psychosocial distress. So now over 10 years ago, there were 15 standards published for care in pediatric psychosocial oncology. These standards were published by a group who came together of experts in pediatric psychosocial oncology, predominantly throughout the United States, but including some Canadians as well. And you can see here that the first standard identified is psychosocial assessment. And while the publication of these 15 standards were vitally important to our field in pediatric psychosocial oncology and really identified what should be the minimum care that families could expect as a pediatric cancer patient, there are little guidelines or instructions for how these standards could and should be implemented. And so I will give a shout out to Dr. Leandra Desjardins, who is doing more work looking at the standards and how they're being implemented across Canada. But our focus on psychosocial assessment was to try and give some definition and some operationalization of what that could or should look like within Canada. The reasons that screening for distress in pediatric oncology have lagged behind our adult colleagues is a number of reasons. One, we have not identified valid and reliable methods of assessment. There are a number of assessment tools, some of those validated within our population, some not. And so we lacked a clear tool that could be used for screening. We also had questions about who should be the patient. I think obviously within our field, we automatically look to the pediatric patient who should be the focus of screening. But we also have caregivers, as Megan has talked about as well, who are critical in the patient's journey. And we should consider their distress as well, as we know that caregivers and the care of the patient are intimately connected. Potentially, there are also siblings often involved in the family, and their distress and their well-being is vitally important as well. And so prior to embarking on this, we asked the question, who is the patient and who should we be looking to screen? Our next question is, who is the respondent? In some cases, we have very young pediatric patients and then require parents to be, or caregivers to be responding on their behalf. So were we looking for tools that patients themselves could answer? Were we looking for tools that parents could respond to on behalf of the patient? And then finally, what is the tool? And as most of you will be aware, pediatric cancer spans a very wide range of developmental stages. And finding a tool that would be appropriate for a newborn or infant, and one that then would suit a school-age child into adolescence and perhaps even longer, can be challenging. Many of our pediatric tools are designed for specific age groups. And so we wanted to think about how do we find a tool that could potentially capture all of these different developmental stages. And so, as I mentioned, our psychosocial team, health team came together to identify our priority. And we decided that it was important to identify and subsequently pilot the implementation of a comprehensive means to assess patient-reported psychosocial health outcomes in children and in their family. And so in order to achieve this, this priority, we started with a scoping review. The scoping review was meant to go through the existing literature and identify what tools might be available. Upon completion of this review, to provide a national recommendation on behalf of ACCESS to the Canadian population to say that this is the tool that ACCESS is recommending that could be used for screening moving forward. And following that recommendation, to work to try to start implementing screening tools in pilot sites across Canada. So to start with a few more details about our scoping review, our specific aims for this review were to identify what instruments are available to enable psychosocial distress screening in children with cancer, survivors of childhood cancer, and family members, as well as to identify what instruments are available to enable psychosocial needs assessments in children with cancer, survivors of childhood cancer, and family members of cancer. This is a real summary of our search terms, but generally we looked for papers that were published with a focus on pediatrics, child, infant, or adolescent patients that had cancer, that looked at surveys and questionnaires assessing psychological distress, depression, and/or anxiety. Our inclusion criteria was to look at children who have or had cancer, the majority of which had to be between the ages of 0 to 21 years. We also included family caregivers of children. We made the decision at this stage in the process to exclude siblings, and that is certainly not to minimize the importance of assessing and providing support to siblings, but for this stage of the project, we did exclude siblings, and we can perhaps talk about that a little bit more at the end. We included studies that reported on patient-reported outcome tools that yielded a direct index of distress, either distress as a whole, depression, or anxiety, or looked at cancer-related symptoms, so pain or fatigue, nausea. We did include patient-reported outcomes focused on parent distress. We looked at patient-reported outcomes tools which yielded a direct index of need, and we included patients from any geographic location. We looked at tools that were included in any setting where cancer care may occur, either the hospital, clinic, or home, and we included systematic reviews. We did have some exclusion criteria that was important. We excluded studies for which children with cancer or their family, we excluded studies for which children without cancer or their family caregivers were more than 20% of the study sample. We excluded studies that focused on only a single diagnostic group. So if the study was only focused on survivor or patients with a brain tumor, we excluded those studies. And we excluded studies that only measured one cancer-related symptom. So if it was a study focused on pain or a study only focused on fatigue, those were excluded. We excluded studies where no quantitative data were presented, tools which assessed satisfaction with care. We excluded case reports and case studies, and we excluded studies that involved positive psychosocial constructs such as hope, coping, or resilience, or neurocognitive functioning or behavioral functioning. And finally, all studies had to be published after 1990. So to give you an overview of our findings, using our search terms and our inclusion-exclusion criteria, we identified over 8,000 potentially eligible studies. We screened 8,400 of those and ultimately assessed over 1,400 for eligibility and included over 500 studies in our final review. We then took those studies and from those studies created lists of all the patient-reported outcome tools that were reported within those studies. I'm now going to share with you the patient tools that we've identified and our steps in identifying a patient tool, and then I'm going to move to our work looking at the caregiver tools. So overall, we identified over 266 patient screening tools that were identified. Taking these 266 unique tools, we then applied some evaluation criteria to these tools. We were interested in the instrument details. So who responded or who's responsible for responding to the tool? What were the domains, the number of items? How long did it take to complete each tool? Were there translations available? And where was there a parent proxy report available? We also looked at the psychometric evidence of each of the tools. Does the tool report on its structural validity, internal consistency, retest reliability, measurement error, responsiveness to change, and were these metrics considered good? And then we looked at clinical feasibility. So if we are talking about a tool that we're hoping to implement within our clinics, is there a cost associated with that tool? Is there a need for training? Do the staff need to understand how to administer the tool? Does the tool have cutoff scores? So can we easily identify within the tool those patients who perhaps are needing further assessment? And is there any support of the tool for integration within the clinical sphere, for example, within the electronic medical health record? Of the 266, we looked at the tools that were highly cited and then applied this criteria. And so I won't go through each of these tools with you, but you can see, and perhaps you recognize some of these tools. Some of these tools met some of our criteria, and some didn't. Ultimately, we landed on 2 tools: the distress thermometer and the Speedy, which met all of our criteria. We then took the results of this work to a town hall that was held by our psychosocial and survivorship research team and engaged with some of the broader community to present the work that we had done, the findings, and ultimately, from the patient perspective, the members of the community endorsed the SPEEDY as the tool to move forward for universal distress screening for our patients. For those of you who are not familiar with the SPEEDY, this tool was actually developed by some of our colleagues out of Sick Kids Hospital, and includes a number of items, symptoms, as well as distress symptoms for which patients and parents can report on how bothered they are by these various symptoms. In terms of the caregiver tools, there was significantly less caregiver-specific tools that were identified. So we identified 48 caregiver screening tools in the studies that we looked at. We applied the same criteria to the caregiver tools, and when we went through and looked at the criteria, again, there was 2 tools that emerged as meeting all the criteria. So the distress thermometer for parents, as well as the psychosocial assessment tool. Our work is continuing with the caregiver tools. We have not yet brought this for a consensus meeting with the community, and so that is something that we will be working to do. We're still quite focused on how we might think to capture financial toxicity, whether there's other missing components within these tools that we're not capturing, and then, as I mentioned, the need for a consensus meeting to finalize our recommendations. I'm going to turn it back to Megan now to share her experience and how she thinks how distress screening might have changed her experience.
Thanks, Fiona. So when I look at the SPEEDY tool that was just on screen and consider how I might have experienced it back in Emmy's treatment or early survivorship, it immediately feels very affirming. I wondered and worried about all the symptoms listed, and to see them in black and white presented by a member of the care team would have validated that these symptoms matter and are worthy of attention. The very existence of distress screening in her care would clearly communicate to me that it's okay to ask about these things, and the team is open to conversations that go beyond her treatment protocol. So I am speaking from the memory of being the parent of a very young child with cancer, but I do imagine that children and youth old enough to complete the questionnaire independently might feel the same way. I wish that Emmy, over these years of survivorship, would have been regularly screened, because it might have helped me navigate the mental health supports that I searched for and arranged on my own. And I'm speaking from a position of relative privilege in terms of education and resources. So I can only imagine the struggle of childhood cancer parents without some of these advantages. Most of all, standardized screening would have flagged Emmy's growing anxiety and led to early intervention, I think, and follow-up that could have at least mitigated years of variable but prolonged distress. So I am very excited that Fiona and her team have recommended such a simple, brief, effective screening tool, and that they are committed to continuing their implementation and evaluation efforts. I believe that standardizing distress screening will transform the experience of childhood cancer patients, survivors, and families for the better. Just as a final note, I'm eager to see and hopefully support the next stage of this work focused on distress screening for caregivers. We, of course, pour everything we have into the healing of our children, and it often leads us to neglect our own well-being. That's a story we know well. But if standardized care one day includes screening directed at us, we'll know. Parents who are very new to this whole journey will know that their psychosocial health matters if they want to be the best possible caregivers for their children during treatment and long into into survivorship. And final quick note is that I also, as Fiona mentioned, I strongly believe that screening for siblings in the future would just be invaluable to the health of families.
Thank you, Megan. Really appreciate you sharing your perspectives. And our hope is that by implementing and standardized screening within the pediatric cancer space, that we will improve the experiences and the quality of life and well-being of patients and caregivers. And so this does bring us to the next steps in our work. And now that we have almost finalized the identification of the tools moving forward, we're going to start thinking about how we might begin implementing these tools into our standard care. We have three projects on the go right now. Looking at various elements of the screening. So within Calgary, we're starting to think about how to implement the SPEEDY into our patient care and clinics. Toronto has been working at implementing the distress thermometer for caregivers, and they're doing that focused on how to integrate that within the electronic medical health record. And Montreal has been taking steps to move the implementation of the psychosocial assessment tool. The nice thing about having each site focus on different elements of the screening is that we'll be able to start our process, learn from the other sites in terms of their challenges and benefits to implement screening. We selected these sites so that we had champions who were present at each site. We wanted variety in terms of the size of site, recognizing here we haven't looked at piloting at perhaps a smaller site, but I think being able to start implementation within these three centers will help us start to work out some of the kinks in the screening. And ultimately, our goal is, can we implement screening at all of our sites across Canada? And based on the experiences learned in Calgary, Toronto, and Montreal, can we then be sites that support implementation of screening at some of the other sites across Canada? And so that brings us to the end of this presentation. Really appreciate you joining. Would like to open the floor to questions from the community.
Okay, hi everyone. Thanks, Fiona and Megan. That was a great presentation, and I especially want to thank Megan for sharing your insights of your family, because that really sort of puts it puts it really into perspective of how important these tools are, and how important this work that Fiona and the team and the whole community are doing. Okay, so we have our first question. So which hospitals are being piloted, and which tools? So I think the tools, Fiona, you mentioned, but maybe could you clarify the sites that are where the tools are being piloted in the three provinces?
Yeah, absolutely. Great question. So um, we are looking at implementing the SPEEDY within the Alberta Children's Hospital in Calgary. I do believe that this is also being implemented at Sick Kids, and perhaps Lindsay can clarify that for me. We're also looking at implementing the distress thermometer for parents within Toronto, and the Sick Kids in Toronto, and then the psychosocial assessment tool within St. Justine in Montreal.
And can confirm that SPEEDY is implemented here at ACCESS-ACCES.
That's great. Thanks. We have we have a really good question about what you see are the biggest barriers after screening and assessment to actually provide support of patients and families, and how can healthcare providers mitigate these barriers? That's probably a very big answer, but maybe to start.
Sure, yeah. So I can speak about just my experience locally and having conversations with our pediatric oncologists here in Calgary. And the first comment that I received was, "Oh my gosh, we're going to deliver this tool," and then and I quote, his comment was, "and open the floodgates." And I think the concern is that by asking these questions, we're suddenly going to generate all of these referrals requiring support. And I think particularly from some smaller centers who might say, we don't even have the resources. Where are we going to send these patients? So I do think that that is a common concern. Um, I think that the idea of screening for distress is really to open a conversation with healthcare providers, and to start that conversation. And it may be a patient says, or a caregiver says, I'm feeling anxious, but perhaps that just starts a conversation with the healthcare provider to say, okay, well, what are you feeling anxious about? Can we talk about that? And perhaps within that one appointment, some of that anxiety can be alleviated. I do think that the idea behind this is to identify patients who might have concerns and who might require additional assessment and perhaps services. So I think starting to think within teams who what resources are available, or what resources maybe aren't available. But are there community resources that you could access as well? Not all of this is going to point to we need a psychologist or we need a psychiatrist to offer this support. I think there are different ways that support can be offered. And so I do think within each center, starting to think about what resources are available, both in-house and perhaps within the community, and are there gaps and what do those look like? So I'm not sure if that answers the question, but
I hope that's a pretty good start. I think that there's probably a whole other webinar that can be done on really that important piece. I'll just share a couple of comments and then go into a next question. We have a comment from Pogo that Speedy is being used for a subset of patients at Sick Kids, and there's plans to implement province-wide, which is great. And then we also have a comment from our contact Carol from the Maritime provinces, the Eastern provinces. She says distress screening in adults, or many provinces have removed the distress thermometer and are using the Canadian problem checklist as well as E or ESAS-R. Yes, yeah.
yes,
I'll
yes.
just I may not know cancer, and she just wants to point out that the checklist covers parking and finances, et cetera. So I just wanted to point that out because you mentioned the financial toxicity piece.
Thank you. And if I could just comment to that, Helen, and so that and appreciate that comment, and so that is the screening tools that have been identified within the adult oncology space and have been used there for a number of years now. Our hope was to find a similar tool to the ESAS-R that had been validated within pediatrics, and we think that the Speedy actually does really map on quite nicely to the ACCESS-R. It's not identical, but identifies many of the same symptoms for screening. The Canadian problem checklist is perhaps something we can look to as an add-on that would consider the costs of parking and any financial barriers that families may be experiencing.
It's great. Okay, I'm just reading through there's a lot of comments, which we will share a lot of these comments with Fiona and team. There's a lot of comments about Speedy and some of the different um, tools. Um, Yeah, again, this idea of, limited resources after screening. So how can we effectively respond to challenges that are identified? So I think Fiona, you tried to address that already. I don't know if you want to add anything in terms of sort of the limited resources
I
piece.
do think, and I will, I don't think it's, well, I think by starting in Calgary, Toronto, and Montreal, I appreciate that those institutions have different resources than some of the other institutions across Canada. I think we thought that these were important places to start to get the implementation underway. But I appreciate that there will be unique experiences in trying to implement these tools in some of the other centers across Canada. And I think working closely with those settings to understand and learn about some of the unique challenges that they may experience will be really important in our work moving forward. So I'm certainly not meaning to kind of pass it off as, figure out the resources and it'll all work. I appreciate that there will be unique challenges, but I think we're keen to learn about what those challenges are and see how we can work through them.
I wonder if I could just
So,
add, I can't speak to the resource challenges and implications, but just from the perspective of caregiver, as Fiona mentioned earlier, it opens a conversation, and it seems part of really broader efforts, just that I know at Sick Kids to in the strategic plan to integrate physical and mental health to break down those silos, but also for parents at the grassroots level to see from this distress screening that physical and mental health are deeply intertwined, and they're both worthy of conversation and questions, and yes, hopefully resources, but there's this first step I think has validity in just that.
yeah, thanks, absolutely. And I think that, with any pilot, you need to start somewhere. It's great that we're starting across different provinces and somewhat different sizes of clinical centers, which helps, I think, some of those lessons learned. I don't, maybe all, because there's a lot of comments here, which everybody who's putting in comments, absolutely, we will share all of these with Fiona, Megan, and the team, and so that they can sort of learn from your comments and so forth. Let me just ask a question while I go through all of these from my end, if that's okay. In terms of sort of smaller centers, I mean, is there a plan to I don't know, like, is the next stage a smaller center, Fiona, or is it sort of sharing the lessons learned with those smaller centers to bring them on board? I think in terms of sort of access and inclusivity, I just wondered if you wanted to comment on that piece.
So I think the next steps absolutely will be a smaller center. I think working out the kinks in terms of implementation at the sites that we're piloting now, and then looking to smaller centers. So I have no agenda on which center that may
Right.
be.
Of
Would
course.
love, if there are individuals on this call who would like to start to think about implementing at their site, if they are not one of the sites that we've spoken about here, would love to start those conversations and start to think about what that might look like. But no specific agenda. Yes.
Great, thank you. Okay, so we have a question about the siblings, which maybe you knew was going to come up. So, are there any tools you came across that include siblings? And I know you had mentioned that it wasn't specifically looked at, but sort of what are the plans around assessing those tools? And again, this might be forward looking. So,
No, and I appreciate this question, and it's funny. Megan and I have been speaking about this, and we have this is we've given this presentation, and the siblings keep coming up, and so there is a definite passion for supporting our siblings, and a definite understanding that siblings have needs as well, and we need to be thinking about how to offer support to our siblings. So we unfortunately, because we did exclude those studies at the outset, we didn't come across any tools specific to the siblings. And off the top of my head, I'm not familiar of any sibling specific measures. I'm sure many of the patient measures we identified could also be applied within the sibling population. So I do think this is an important piece. I understand when we're talking about availability of and resources that not all centers have the capacity to also look at and support siblings. And so that would be something we'd have to take into consideration. But definitely, and I wonder, even if we think of something like, as was mentioned, the Canadian problem checklist, is there opportunity to add a couple of questions about siblings in the family and whether supports may be needed. So it is there's no direct plan for siblings immediately, but the importance of siblings that that message has been received loud and clear, and so I do think it's important that we think about what we can do moving forward.
That's great, thanks. And we actually, I will share with you that we have some reach outs from maybe smaller centers already that we can share after
Amazing.
Fiona. So that's
Amazing.
great. And thanks, Carol, for that comment. Well, I mean, we're gonna capture all of these great comments because there's really a lot of great feedback here. I do want to sort of mention a comment, which is a little bit of a comment, but maybe a question about patient organizations as they might be interested in these types of tools and how they can maybe be involved and help with this type of work.
Yeah, so I think about and by patient organizations, Helen, community-based organizations, is that?
Yeah, I think so. I mean, it's not they mention sort of certain types of cancer. So a lot of organizations focus on certain types of cancer. But yeah, I think community organizations that focus on certain types of pediatric cancers might be interested in knowing about this work or helping or helping. I mean, I'm maybe adding to the comment, but maybe they would probably see this as an invaluable support. So how could they maybe get involved or help with accessibility or dissemination or sharing of information?
Yeah, absolutely. So I think and I know there are a variety of community-based organizations that offer different services. I think getting in touch with your local institution as being potentially a source or a resource for families. I think that would be important. I think so knowing locally who those organizations are and are they a potential source for referral or place for families who might be looking for supports, whether that be for the patient, perhaps siblings, perhaps parents. So I think being aware of those organizations and what they offer will be critically important moving forward, so that when the healthcare team perhaps identifies that there is a family looking for supports in a particular area, that they know what services might be available, as I had mentioned, both perhaps within the institution, but also in the local community.
That's great. Thanks. And thanks, Chiquita, for the additional context. Chiquita was talking about hereditary organizations as well. And she brings up the good point, and this links back to the siblings piece. They can often also become patients in different ways.
Absolutely.
They donate organs, tissue, blood, etc. So that's another area of needed support. So just wanted to add that there. I think we're getting close to the time. I don't see any other questions, but again, there's lots of great feedback here. So I really want to thank everybody. If I didn't share your comment, it's not that it's lost, it's that we will share all of these with the team after and can help make connections and so forth afterwards. So really thanks everybody for this really great great. I know the discussion happened on a text chain here versus in person, but we will share all of this and there'll be connections made after. So really thanks everybody for all of your comments and questions, which will all be captured and shared. And I want to turn it over now. I think Leandra is going to give us some closing remarks. And yeah, so Leandra, over to you.
I just wanted to start with a big thank you to Fiona and Megan. That was a really helpful talk. I mean it by helpful. I think the applied focus is enormous and giving guidance to people on where to go next with screening. An amazing thank you to the leadership of Fiona because this is a was a Herculean task. As she mentioned, over 8,000 studies were screened as part of this process, and we had really stalled out, since 2015 it was a recommendation, but even before that, I think we knew we were hoping to start screening, and so having this pathway forward is so helpful and starting these conversations also with the community on where we can go. So thank you for that. And Megan, um, everything you said was so perfect, and I believe should be the introduction to every conversation about psychosocial screening in Canada. So thank you for sharing that as well. I was really touched and just really reinforces for me, and I know for everyone here, the importance of this work. So thank you for lending your voice to that and advocating. Um, and now I will shamelessly, I guess, hope that mention that anyone who's coming to the Access annual meeting soon, or sort of suggest that people can reach out to the presenters directly, and or also come speak to any of us at the upcoming Access annual meeting about screenings. As you can see, everyone is very excited and motivated about screening, and I think that really matters is this buy-in. So if you're here, clearly there's some interest, and so we would love to continue the conversation with you as well around this. So thank you for the interest of the audience as well, and to Access for hosting this important topic. And then I am also putting in a mention about an Access survey to share your suggestions for future topics. We do want to hear from you. Things that we find interesting. We're very excited when other people find interesting and come to these webinars, but we also want to make sure that we're meeting your needs. So please feel free to scan the QR code to share your feedback, and then also let us know what you would like to hear about and what's important to you in terms of psychosocial and survivorship care.
That's great. Thanks, Leandra, and thanks everyone.